Request Dr. Sindhu to enlighten us. Sindhu is consultant vitreoretinal surgeon at Little Flower Hospital, Angamali.
Good evening all. First of all, I would like to thank KSOS and Thomas Cherian sir for giving me an opportunity to speak in KSOS. So today in this next 10 minutes, I'll be discussing about toxic anterior segment syndrome, how you differentiate it from endophthalmitis, and in very short about the management. So this is the normal day one post-op of an anterior segment surgeon. Patient is happy, surgeon is happy. But once in a while, this is the scenario. So now the question is whether it is an inflammation or whether it is an infection. So let's refer to VR colleague. What next? So let me come to two case scenarios first. A 55-year-old female, a diabetic, with an uneventful cataract surgery on day one post-op, comes with a visual acuity of counting finger close to face, but the fundus details are hazily seen. As in the picture, you can see conjunctival congestion, circumcorneal congestion, 1 millimeter hypopyon, fibrin sitting over the IOL. The patient was immediately started on frequent topical steroids along with the topical antibiotics and cycloplegics, reassessed the same day evening, and the next picture shows day 3 post-op with a clear cornea, resolved hypopyon and good view of fundus with a visual acuity of 6/9. This was a case of toxic anterior segment syndrome. Coming to the next scenario, a 66-year-old female with an uneventful cataract surgery, day 1 post-op everything was normal, but day 3 comes with a visual acuity of perception of light. You can see the conjunctival and circumcorneal congestion, corneal edema, 3 mm hypopyon, and there is no view of fundus. Then we got a B scan done to see a clump of vitreous echoes with the choroidal thickening. As the visual acuity was perception of light, the patient underwent pars plana vitrectomy with intraocular antibiotics along with oral antibiotics and systemic steroids. And next post-op day, the patient received topical steroids, topical antibiotics and cycloplegics. Now this is the photo showing the post-op day 14 with a visual acuity of 6/12, and this was a case of acute post-operative endophthalmitis. So now what is TASS? It is an acute sterile post-operative inflammation following anterior segment surgery. Remember, if there is a traumatic surgery or if the patient has got a traumatic cataract or a patient you are operating with a pre-existing uveitis or a fuchs or pseudo-exfoliation, or in a situation where you use CTR, iris hooks, you can get normal than excess inflammation. That doesn't come to TASS. So this was known in 1980s as sterile endophthalmitis, and it was renamed by Monson et al. As TASS in 1992. So when an outbreak of TASS comes, every time it's difficult to find out the source. As discussed earlier, the most common causes is the improper cleaning of the instruments. Other is anything which goes into the eye, whether it is your BSS, whether it is your trypan blue, whether the viscoelastic or with your intraocular lens, anything can cause this TASS. So what happens is when the toxin enters the eye, there is severe inflammatory response with anterior segment damage. If not treated properly, can lead to corneal decompensation, intractable glaucoma and cystoid macular edema. So when a TASS outbreak occurs in an institute, the surgical faculty halts the procedures and thorough investigation is taken. It is discussed among the colleagues and other colleagues in the region, and you have to find out the source. And the staff theatre OT protocols has to be reviewed and if necessary has to be changed. Now endophthalmitis is purulent inflammation of the intraocular fluids caused by infection. So time of onset, day 1 post-op, more likely to be TASS. Usually it occurs within 12 to 24 hours post-surgery. However, there are reports of late onset TASS after tapering the topical steroids. Endophthalmitis usually seen 4 to 7 days post-surgery. However, there are reports of endophthalmitis seen even on day 1. So based on the symptomatology, pain is more in favor of endophthalmitis. However, you can get pain in TASS if there is high intraocular pressure. Both the conditions can cause defective vision. Lid edema, conjunctival congestion, purulent discharge more in favor of endophthalmitis. Always never forget to look the surgical incision site, especially the upper lid has to be retracted and seen to see whether there is any corneal infiltrate. And the sections has to be inspected for wound leak or iris prolapse. Remember, once the cornea is involved, the game in endophthalmitis is gone and the prognosis is poor. Corneal edema can occur in endophthalmitis. The limbus to limbus corneal edema is classic of TASS. Iris, you can get a fixed dilated pupil, a sectoral or diffuse iris atrophy. Endophthalmitis, many a time we see that pupil is myotic and resistant to dilatation. Fibrin and hypopyon can occur to varying levels in both the scenario. Fundus, remember in toxic anterior segment syndrome, there is no involvement of the posterior segment, there is no vitritis, so if you don't have a fundus view, go for a B scan, the B scan will be normal in TASS. Whereas in endoph, sometimes you can see the exudates, when you don't have any glow or yellow reflex, go for a B scan. You can also encounter presence of retinal hemorrhage, periphlebitis and occlusions in endoph. The intraocular pressure can be normal in TASS or it can be high if there is trabecular damage. In endophthalmitis, it can be normal, low if there is choroidal and retinal detachment associated with it. It can be high also in inflammatory condition. Culture is always sterile in TASS. It can be positive in 60 to 65% case of endophthalmitis. So if there is a suspicion whether it is TASS or endophthalmitis, day 1 post-op, immediately put the patient on topical Predfort hourly and give along with it topical antibiotics, and if the IOP is high, start anti-glaucoma medications also. Before you leave the OPD, reassess the patient same day evening. Look if there is any signs of improvement. If there is signs of improvement, continue same treatment and see the patient next day. However, in your reassessment, if there is no improvement, go for a B scan, and to be on the safer side, consider it as endoph and do tap and injection. If it is an acute postoperative endophthalmitis, as per the EVS guidelines, if the initial visual acuity is PL+, go with the pars plana vitrectomy. If the initial visual acuity is hand movements or better, first tap and inject is performed, and after 48 hours the patient is reassessed. If there is no improvement, go ahead with pars plana vitrectomy. Now, after the ESCRS guidelines have come, especially with the availability of wide-angle viewing systems with smaller gauge instruments and 36 mm cannula and lot of vitrectomy facilities have evolved, the ESCRS guidelines have suggested immediate and complete pars plana vitrectomy with intraocular antibiotic as the gold standard, because it is according to the Latin synonym ubi pus ab evacua. Wherever there is a pus, it has to be evacuated. And the tap plus intravitreal injection is being considered as a gold standard. So the take-home message is differentiating between endophthalmitis and TASS is purely a clinical diagnosis, and you can take the help of a B scan for the same. Both the conditions have to be identified promptly. Both of them the treatment has to be started immediately for a successful outcome. Thank you.
Thank you, Dr. Sindhu. I think just stay back. We'll have panel discussion at the end of the meeting. Wonderful presentation.